So the clinical presentation, a first episode, psychosis across different migrant and ethnic minority groups in Montreal. Thank you.
Okay, well, thank you for welcoming me here in Montreal. It's a real pleasure to be here. I actually migrated myself to Montreal in 2008, and I started working here at PEP as a research assistant. And I had a bit of a migrant experience myself because it was winter time. And on my way to my job interview here at PEP, I got out at the wrong bus stop and got stuck in the snow, like up to my waist. So unfortunately, I made it to my job interview and finally got hired. So I guess that's a good thing because that's finally the reason why I'm here. So I've worked with data from PEP and did a study. And the study is on the clinical presentation of first episode psychosis across different migrant and ethnic minority groups. And I also will be presenting some new data that I've been working on in the context of my PhD project. So first of all, as Lawrence already pointed out, migrants are at increased risk for developing psychosis. The risk is about 2 to 3 times as higher than non-migrants, but there's a huge variety based on source country. So migrants from with a personal parental history of migration that come from low or middle income countries are like about 5-fold increased risk for developing psychosis. And the question is really like why is this risk so much increased? And it's been proposed that this has to do with selective migration. And selective migration also can be, it's also been named as genetic confounding. And this means that people that are genetically at risk for developing psychosis are more likely to immigrate than those who are not. So whether these people would have migrated or would have not migrated, they would have developed the psychosis anyways. So there's also post-migration factors, which basically, with that I mean factors that are associated with having a minority position in a host in a new society, or has to do with misdiagnosis. And misdiagnosis basically means that culturally appropriate material is judged as being a psychosis because there's a difference between the cultural background between clinician and patient. So maybe everybody can think a little bit for themselves what they think is the most likely explanation. And we have done this study here where we looked at the differences in clinical presentation. And with clinical presentation, I mean the symptoms that someone presents with, psychotic symptoms that someone presents with when they entered PEP services. And we looked at positive symptoms, so delusions, hallucinations, bizarre behavior, positive formal thought disorder, negative symptoms, so alogia, like poverty of speech, apathy, avolition, and we also looked at a measure of general psychopathology, so which includes depression, anxiety, somatic concerns, so yeah. And so maybe again you can think for yourself, like what would your hypothesis be? Do ethnic minorities present with increased severity of symptoms, decreased severity, or do you think that there are no differences? So I want to make a quick comment on why we would actually be studying this. Why study clinical presentation? I think clinical presentation is very important because it basically shapes an evaluation, a clinician's evaluation. It is important for treatment decisions. It is important for the pathway to care because if somebody, like the way somebody presents with what type of symptoms will influence the decision of clinicians where to send that person and what kind of treatment that person is going to receive. Also, we decided to study clinical presentation because in that way we can overcome limitations of diagnostic criteria that are more black and white. So now we could look at the whole range of like the spectrum of symptoms that somebody presents with. So this study was carried out. I might have been a little bit generous with my with my circle there, but this is I we used PEP data, and these are patients that presented at our services in the southwest island of Montreal. And in this area, there's a large population of people with a personal or parental migration history. And we ascertained ethnicity by looking at the country of birth and the country of birth of the parents. And we took the country of birth of the mother if there was a difference between parental country of birth. And we divided this in either African, Afro-Caribbean, Asian, Middle Eastern and North African, and Central South American, and used a Western or like European and North American, and used a reference group of English or French-speaking Canadians that did not have a personal or parental history of migration. So, well, as has been already several presentations at this conference has talked about this, we have a huge, rich database at PEP where everybody that enters the program is assessed on a variety of symptom scales, and we also have quite some illness characteristics. So we used the SAPs for positive symptoms, for the SANS for negative symptoms. There's a subsection of PANS that is only that is measuring general psychopathology, so we use that for as a psychopathology measure, and we use SCID for having an idea of what the final diagnosis was, and a course which basically assesses the duration of untreated psychosis. You go back in the timeline of a patient's start of psychosis and prodromal symptoms, and we reach consensus on what the duration of untreated psychosis and the age of onset. So here you can see that over an 8-year period, 289 patients that were consecutively entered the program, we knew the ethnic background. And so you see that half of the patients has a personal or parental migration history. And the largest group consists of the African and Afro-Caribbean and the European and North American group, whereas the European North American group was mostly the people from the US. So let's look at the differences in illness characteristics and demographics. So there were actually a lot of similarities. So age at onset was quite similar, DUP similar, the distribution. So in all ethnic groups, the majority of the patients were male, which is pretty much the same all over. And the only difference that we found in terms of demographics and illness characteristics was that African and Afro-Caribbean patients were more likely to be referred from the emergency room, which is something that I think Kelly is going to be presenting on that. That has been a finding that has been found before in Montreal, and it's also been found in Britain. There seems to be also difference with the Central and South American group, but that was there was a smaller sample size, so that was not significant. So let's look at the differences in symptoms. Were there ever any differences when these people presented at the PEP clinic? Well, we see that we see a trend, but there were no significant differences in terms of positive symptoms. There were differences in terms of negative symptoms, and African and Afro-Caribbean patients were especially more likely to present with poverty of speech. And lastly, there was a difference in general psychopathology, where the same ethnic minority group was more likely to have higher scores overall in general psychopathology, and these were mainly caused by higher scores on uncooperativeness, preoccupation, and poor attention. So, in conclusion, we actually found quite some similarities in core symptoms, so in positive symptoms, but also core illness characteristics. So it was not like ethnic minorities have an extremely different age at onset, or we also didn't find differences in DUP. And also, if we look at diagnosis, it is not like there is a different distribution in terms of non-effective versus effective diagnoses. I think that this does not support the notion that misdiagnosis is a good explanation for increased rates of psychosis among immigrants, because I think that the ethnic minority background can have maybe an influence on the content of a delusion, or the type of some influence on the type of symptoms someone is presenting with, but the illness as in presentation is not very different based on ethnic background. So if we look, so these are the similarities that we found, but if we look at the differences that we found mainly differences in poverty at speech and uncooperativeness at baseline. I think that it's very possible that these increased scores are not so much due to the psychosis itself, but there may be already external factors like pre-existing adverse social economic circumstances. Maybe there's less awareness of mental health issues among these communities, and therefore a underuse of mental health community services. So at the start of psychosis, these may be reasons why the road to care is more often passing by emergency services, and then maybe it is not very surprising that by the time that they enter the program, they receive a higher symptom rating on uncooperativeness or poverty of speech. I think that may be more due to the pathway into care than the illness itself. So I want to quickly also talk about some new project that we've been working on. It is a very different project. We are working with a Swedish database of 50,000 males that were assessed for the army at 18 years old. And with that database, we wanted to test the selective migration hypothesis. The idea that immigrants are actually a negative selection of the original population, and therefore more likely to develop a psychosis once they have migrated. So these males were assessed at age 17, 18, and we followed them up over time, and we looked at the group that were to immigrate, and a group that were to not immigrate, that would stay in Sweden. And we compared these groups on risk factors for schizophrenia that have been previously identified in the same cohort. So we know that there is a relationship between several factors and an increased risk of schizophrenia, and we looked at whether these are more prevalent among immigrants compared to non-immigrants. So here are some results, and we found that poor social adjustment or disturbed behavior there were no differences between non-immigrants and immigrants. There were no differences in terms of non-psychotic psychiatric disorder at assessment. So these people had anxiety or depression or personality disorders at time of assessment, but that was not more likely to be present among immigrants compared to non-immigrants. There was no differences in family history of psychosis, like having a parent with schizophrenia. So immigrants, so those people that were going to immigrate later in life, were more likely to be brought up in the city, and they were more likely to use cannabis. And on the other hand, they were having generally a higher IQ than the Swedes that did not immigrate. So the people that actually immigrated had a higher IQ, and this was a dose-response relationship. We put these risk factors in a kind of hypothetical model, and based on their profile at assessment, looked at what is the percentage that these different groups will develop schizophrenia later in life, and it was very similar, so it was about 1% for both groups. So this basically, to come back to one of my first slides, so we did not find a lot of support for the idea that selective migration is responsible for increased risks of psychosis among immigrants, nor for misdiagnosis. Most studies that have been done so far give most support for post-migration factors that are related to having an ethnic minority position in a new society. So I want to thank everybody, and I want to thank my co-workers here at PEP and those in Holland. Thank you very much.
Thank you very much. Once again, are there any questions or comments directed to the speaker? Please, Ashok.
Yes. So we published a paper on clinical presentation in the Canadian Journal of Psychiatry. So please send me an email if you want to have a copy, and or Dr. Mala, who will have a copy available as well.